Welcome to the Rad-On Smart Review Head and Neck Cancer series.
Today we're diving into a simulated oral board examination. The focus will be entirely on oral cavity cancers, oral tongue, floor, mouth, and the related structures. We have 5 case blocks, all structured for radiation oncology residents.
That's right, and for this session, I'll be taking on the role of the examiner. I'll present the cases, I'll probe the rationale, and I will definitely challenge some assumptions.
And I'll be the examinee. I'll be providing the structured, board-ready answers, citing the evidence, and talking through the technical side of things. I'm ready.
Excellent. So let's start with Block 1. This is the comprehensive longitudinal case, oral tongue. Our patient is a 54-year-old male. He presents with a painful ulcer on the right lateral side of his tongue. It's been there for about 3 months. He has a pretty significant 40-pack year smoking history and also reports daily heavy alcohol use. On exam, I find a 2.5 centimeter ulcerated lesion. It's on the right lateral oral tongue. It's mobile, doesn't cross the midline, and critically, there are no palpable lymph nodes in the neck. So let's start with the basics. Orient me to the anatomy. What is the precise posterior boundary that separates the oral tongue from the base of the tongue?
Okay. So anatomically, the oral tongue is the anterior 2/3 of the mobile tongue. The posterior boundary, the line that separates it from the oropharynx, is defined by the circumvallate papillae.
And what's just behind those?
Just posterior to that V-shaped row of papillae is the sulcus terminalis. And, understanding that boundary is absolutely critical. It separates 2 totally different tumor biologies, different drainage, different treatments.
Good. Now, epidemiologically, how does this patient's risk profile, the smoking, the alcohol, inform your suspicion about the tumor biology, especially compared to a typical oropharynx cancer we see today?
Well, this patient is the classic textbook case for oral cavity squamous cell carcinoma, heavy tobacco and alcohol. This leads to what we call field cancerization, where, huge areas of the mucosa have been exposed to mutagens for years.
And what does that mean biologically?
Biologically, these tumors are usually driven by things like P53 mutations. They're genetically unstable. They tend to be more aggressive locally, invading muscle and nerves. It's a sharp contrast to, say, an oropharynx cancer.
How so?
Because the dominant cause in the oropharynx now is HPV, human papillomavirus. Those tumors are P16 positive. They occur in younger patients, often non-smokers, and they carry a much better prognosis. They're just more sensitive to our treatments.
A perfect contrast. That geographic distinction is everything. Okay, let's pause for a moment here. Teaching Pearl. Always locate the sulcus terminalis and circumvallate papillae, and recognize that the clinical behavior for tobacco alcohol-driven oral cavity cancer is fundamentally different and often more challenging than HPV-driven oropharynx biology. All right, let's move to staging. A biopsy confirms invasive squamous cell carcinoma. A preoperative MRI measures the superficial size at 2.5 centimeters. But here's the key detail. The pathology report states the depth of invasion, or DOI, is 9 millimeters. Clinically and radiographically, the neck is negative. So using AJCC 8th edition, what is the clinical T-stage, and why is DOI now so integrated into oral cavity staging?
The clinical T-stage here is T2.
And why is that?
Because in the 8th edition, the T-stage isn't just about surface size anymore. It's a combination of size and DOI. The lesion is 2.5 centimeters, so by size alone, it would be T2. But the 9 millimeter DOI is really what's driving the stage.
Okay, tell me more about that. Why does DOI have so much prognostic power in the oral tongue specifically?
Right.
You don't see this same emphasis in, say, laryngeal cancer.
Right. It's paramount in the oral tongue because of the anatomy. The tongue is just packed with lymphatic channels and mobile muscle. As soon as that tumor invades vertically, past the mucosa and into the muscle, it gains direct access to those deep lymphatics.
So it's about metastatic risk.
Exactly. It dramatically increases the risk of occult nodal metastasis, which, as you know, is the single most important prognostic factor we have. Study after study has shown that DOI is a better predictor of nodal mets than the surface size is.
Okay. And what are the specific non-negotiable DOI thresholds that we must have memorized for the boards?
The 2 key numbers are 5 millimeters and 10 millimeters.
Explain how they work.
So if you have a T1 tumor by size, let's say 1.5 centimeters, but the DOI is greater than 5 millimeters, it automatically gets upstaged to a T2. And if you have a T2 by size, like our patient, but the DOI goes over 10 millimeters, it gets upstaged again to a T3. So our 9 mm DOI is a very high-risk feature. It's right on the cusp of that T3 threshold, which makes us extremely worried about the neck, even though it's clinically N0.
An excellent explanation. You've hit on the core principle, teaching Pearl. Don't treat depth of invasion as a mere footnote in the pathology report. 5 millimeters and 10 millimeters are the staging pivots in oral cavity cancer that directly quantify nodal risk and mandate comprehensive neck management. All right, let's follow this patient through his treatment. He undergoes a partial glossectomy and a comprehensive elective neck dissection on the right side. The final pathology is in. It confirms a 2.5 centimeter moderately differentiated SCC. DOI is 9 millimeters. Margins are all negative at 5 millimeters. But now, here's the critical finding from the neck. 2 positive lymph nodes in the right level 2 basin. The largest node is 1.8 centimeters. And importantly, the pathologist explicitly states there is no extranodal extension, no ENE. 30 nodes were examined in total. So 3 questions. First, what is the pathologic N category? Second, what is your definitive adjuvant recommendation? And third, anchor that decision in the landmark evidence.
Okay. First, the pathologic N category is PN2B.
Why PN2B?
It's defined by multiple ipsilateral positive nodes, none of which are larger than 6 centimeters. And the key for the B designation is the absence of extranodal extension.
Perfect. Now, your adjuvant recommendation.
My recommendation is for post-operative radiation alone.
Radiation alone. Why not add chemotherapy? He has 2 positive nodes?
Because he falls squarely into the intermediate risk category. He has 2 positive nodes, which is an intermediate risk feature, but he lacks the specific high-risk features that have been proven to benefit from adding concurrent chemo.
And what's the evidence that defines that distinction?
It's anchored by the 2 classic Phase 3 randomized trials, RTOG 9501 and EORTC 22931.
Tell me about them.
Well, both trials compared postoperative radiation versus postoperative chemoradiation using cisplatin, and the data from both, when you look at it together, showed a significant improvement in both overall survival and locoregional control when you added cisplatin, but, and this is the key, only for the patients who had high-risk pathologic features.
And what were those high-risk features?
The 2 non-negotiable high-risk features defined by those trials are positive surgical margins and the presence of extranodal extension, or ENE.
So what about patients like ours, intermediate risk?
The trials showed that patients with intermediate risk factors, like multiple positive nodes without ENE, which is our patient, they did not get a statistically significant overall survival benefit from adding chemo. All it did was add toxicity. So since our patient has negative margins and no ENE, radiation alone is the standard of care.
That is a well-reasoned, evidence-based answer. You've correctly placed him in the intermediate risk group. Teaching Pearl. 2 nodes without ENE or a single node fall into the intermediate risk category. Treat with postoperative radiation therapy alone. You reserve postoperative concurrent chemo for the proven high-risk triggers, ENE or a positive margin. Okay, now let's get into the technical details. Outline your radiation planning and technique for this patient. Talk me through simulation, your target volumes, the dose prescription, and critically justify your decision on covering the contralateral neck.
Okay, so simulation has to be meticulous. We need robust immobilization, a thermoplastic head and shoulder mask. A pre-radiation dental eval is, of course, non-negotiable. For the planning stand, a CT with IV contrast is ideal, helps delineate the vessels and nodes, and I would absolutely want a fusion with the pre-op MRI to help define the primary tumor bed, especially with that 9 millimeter DOI.
Good. And your volumes and dose?
I'd use a simultaneous integrated boost, or SIB, approach, probably over 33 fractions. I would prescribe 60 gray to the high-risk CTV1. This would include the post-op primary tumor bed and the involved dissected ipsilateral neck levels, especially level 2.
And the elective volumes?
The elective nodal regions, or CTV2, would get 54 gray. On the right side, that would be levels 1, 3, 4, and potentially 5.
Okay, now the big question. The contralateral neck. What do you do with it?
For this specific patient oral tongue primary, high DOI of 9 millimeters and documented N2B disease, I have a very, very low threshold for treating the contralateral neck.
Why is that?
Oral tongue primaries are notorious for having bilateral drainage, especially once they get deep. That deep vertical invasion gives them access to lymphatics that can cross the midline. So the risk of occult contralateral nodes in a patient with this many high-risk ipsilateral features is well above the 10 to 15% threshold where we justify elective treatment.
So your recommendation is to treat it.
Yes. I would include the contralateral neck, levels 1 through 4, to the elective dose of 54 gray. It's the board-safe and clinically correct approach for this stage of disease.
And when you do that, you're obviously increasing the toxicity risk. How do you mitigate that, particularly xerostomia?
That's where IMRT or VMAT planning is essential. By treating bilaterally, we're definitely putting the contralateral parotid at risk. So we use aggressive planning constraints to spare as much of that gland as possible while still covering our targets. The goal is to keep the mean dose to the contralateral parotid under 26 grays, or even better, under 20 grays, to give the patient the best chance of long-term salivary function.
Excellent. You balance the oncologic need with the functional preservation. Teaching Pearl. For oral tongue cancer, once depth of invasion is meaningful, over 5 millimeters, and nodes are positive, bilateral elective neck coverage becomes the clinically defensible default approach. Let's shift to supportive care, which is absolutely vital. What do you tell this patient about his prognosis, and what are the dominant, acute, and late complications you need to manage?
For prognosis, I'd explain that our goal with radiation is durable locoregional control, which is, the first step towards cure. I would stress that his prognosis is driven by those key pathologic factors, the 9 millimeter DOI and the N2B nodes. I'd highlight the good news, negative margins, no ENE, but I'd be realistic about the recurrence risk.
And the toxicities. Start with the acute phase.
The acute toxicities are severe. We're talking grade 3 mucositis, which causes intense odonophagia or painful swallowing. This often leads to dehydration and weight loss. We'll see marked dysphagia, loss of taste, and a pretty bad dermatitis in the neck.
So how do you manage that proactively?
Proactive care is everything. Aggressive nutritional support from day one, that often means placing a prophylactic PEG tube. Preemptive swallowing therapy with speech and language pathology is also key. And of course, aggressive pain control with scheduled narcotics.
Okay. Now what about the late toxicities, the ones that affect quality of life for years?
The late effects are chronic and really demand lifelong management. The big ones are chronic xerostomia, or severe dry mouth, progressive fibrosis in the neck, and chronic dysphagia. There's also a high risk of dental decay, osteoradionecrosis of the mandible, and lymphedema.
You mentioned osteoradionecrosis. How do you mitigate the risk of ORN, given the mandible is going to get a high dose here?
ORN prevention is built on a few pillars. First, the pre-treatment dental clearance is mandatory. Any bad teeth in the high-dose field have to come out with enough time to heal. Second is meticulous planning to minimize the mandible dose where we can. And third is just rigorous long-term management, lifelong fluoride, frequent dental cleanings.
That's the comprehensive approach we need to see. Teaching Pearl. Oral cavity cancer success is equally defined by supportive care as it is by dose delivery, proactive management of nutrition, swallow function, dental prevention, and careful mandibular dose planning are mandatory. Now for the twist and block 1. Let's reset. Same patient, same tumor, 2.5 centimeters, DOI 9 millimeters. He goes to surgery, but this time the final pathology report shows tumor is present on ink at the deep margin of resection. The nodes are pathologically negative, PN0. What is the single most significant change in your management recommendation, and what evidence drives that change?
The change is immediate and absolute. A positive margin is one of the 2 highest risk features. This now mandates post-operative concurrent chemoradiation.
So you're adding chemo.
Yes. My recommendation would switch from radiation alone to adding weekly concurrent cisplatin, and I would also incorporate dose escalation to that specific positive margin region.
Tell me about the dose escalation. What dose are you aiming for at that positive margin?
The positive margin site needs to get the highest dose. So while the rest of the high-risk bed might get 60 grays, I would boost that specific positive margin area, our CTV, 1 to a total dose of 66 gray, or maybe even up to 70 gray, given concurrently with cisplatin.
And the evidence driver is the same.
Yes, it's still RTOG 9501 and EORTC 22931. They showed that positive margins carried a very high risk of local failure that was effectively mitigated by adding concurrent chemotherapy. It led to a real survival advantage.
Exactly. The positive margin is the line in the sand. Teaching Pearl. Close margin means boost with radiation therapy alone. A positive margin means mandatory concurrent chemo plus radiation therapy. Okay, let's transition to block 2, floor of mouth. We have a 65-year-old woman. She has a 3.5 centimeter anterior floor of mouth lesion. On exam, it feels fixed to the gingiva and the underlying mandible. She also has a mobile, palpable node in her left level 1. What's your required workup, and why do you absolutely need both CT and MRI for this specific subsite?
The workup starts with a thorough physical exam, bimanual palpation to really assess fixation to the bone. Then biopsy, and of course, full dental clearance is a must. And for imaging, we need both CT and MRI.
Why both? Don't they show the same thing?
No, they provide complementary information. The CT scan is far superior for looking at the cortical bone, the hard outer shell of the mandible. It shows us erosion or breakthrough. The MRI, on the other hand, is much better for evaluating soft tissue and, most importantly, for detecting early invasion into the marrow space inside the bone.
So CT for the shell, MRI for the inside.
Exactly. You can have marrow involvement even before you see a clear cortical break on CT.
And what's the staging implication of documented mandibular invasion?
Invasion through the cortex into the mandible automatically elevates the stage to T4A. We have to distinguish this from T4B, which is invasion of deeper structures like the masticator space or skull base.
Oh.
T4A means it's locally advanced, but likely still resectable with a major operation.
Good. You need both to get the full picture. Teaching Pearl. CT for cortex, MRI for marrow. Always obtain both in the floor of mouth or alveolar ridge to accurately delineate T for a mandibular invasion. And know the specific anatomy that pushes the stage to an unresectable T4B. So in this patient, the CT showed definite cortical erosion and the MRI confirmed marrow involvement. She undergoes a segmental mandibulectomy, free flap reconstruction, and a bilateral neck dissection. Pathology comes back. PT4E due to the bone invasion. 2 ipsilateral level 1 nodes are positive and 1 contralateral level 1 node is positive. And here's the critical finding. Extranodal extension, ENE, is present in the largest node. Margins are negative. What's your definitive adjuvant recommendation and specify your dose plan for this high-risk scenario? The presence of extranodal extension is the definitive trigger. It's the highest risk feature, so my recommendation is mandatory postoperative concurrent chemoradiation with weekly cisplatin. And your dose plan. How do you approach the SIB for this complex case?
The ENE region and the primary bed require the maximum dose. I would prescribe 66 gray to the CTV1. That volume would encompass the entire post-op bed, the flap interface, and the region of the neck where the ENE was found.
And the other volumes?
The remaining high-risk areas, so the involved nodal basins, levels 1 bilaterally, would receive 60 grays as CTV2. And given the midline primary and the contralateral positive node, elective coverage of the remaining at-risk neck levels bilaterally is mandatory. So levels 3, 4, and 5 would get 54 gray.
That's the textbook approach for managing ENE teaching Pearl. Extranodal extension is the clearest, most robust board trigger for mandatory postoperative chemoradiation, based on the survival benefits shown in RTOG 9501 and EORTC 22931. Now, a critical logistical problem. The patient have 3 bad carious teeth right in the proposed 66 gray field. She's just had this huge surgery and we need to start her adjuvant treatment soon. What do you do about those teeth and what timing do you insist on?
This is a major safety issue. You can't ignore it. Any non-restorable teeth in a high-dose field, especially over 60 gray, must be extracted before we start radiation.
Why is that so critical?
Because if she needs an extraction years down the road after high-dose radiation, the risk of severe osteoradionecrosis, or ORN, is extremely high. And in her case, the blood supply to her jaw is already compromised from the surgery and flap. It's a recipe for disaster.
So what's the plan? How long do you wait?
We coordinate with dental for agent post-op extractions, and then we have to wait for healing. While we want to start treatment within that 6-week window after surgery, safety comes first. I would insist on a minimum of about 2 weeks, ideally 3, of healing time after the extractions before we start radiation. Preventing lifelong debilitating ORN is non-negotiable.
Safety first? Absolutely. Teaching Pearl? Pre-radiation therapy dental clearance for high-dose fields is essential. This prevents the worst complication you can create: post-radiation therapy extractions and severe osteoradionecrosis. Okay, a twist for block 2. Same case, but now the imaging shows only minimal cortical scalloping on the inside of the mandible, no definite breakthrough, and the MRI shows no marrow signal abnormality. How does that subtle finding change the surgical approach and the T-stage?
That's a very important distinction. If we only have superficial scalloping without a true cortical break or MRI-confirmed marrow involvement, then it doesn't automatically meet the criteria for T4A.
So what can the surgeon do differently?
This allows the surgeon to potentially perform a marginal mandibulectomy instead of a segmental one.
And what is that?
A marginal mandibulectomy removes just the top portion of the mandible, the alveolar ridge, but it preserves the inferior border. The jaw's continuity remains intact. This avoids the big defect and the need for a free flap. The functional outcome is just vastly better for the patient.
And the T stage.
The T stage would then fall back to being based on size and depth of invasion, so probably a T2 or T3, not an automatic T4A. It really highlights why that detailed multimodality imaging is so important.
Exactly. Don't overstage and overtreat if you don't have to. Teaching Pearl. Don't reflexively call every floor of mouth lesion T4 a true invasion through the cortex and into the marrow matters. Superficial scalloping can allow for a marginal mandibulectomy and a lower T stage. Let's move to block 3. Buccal mucosa. A 70-year-old man had a 4-centimeter right buccal tumor resected. Pathology is PT3, margins negative, nodes negative. But postoperatively, he has new numbness of his right lower lip and chin. And the path report explicitly states paraneural invasion, PNI, involving a large named nerve. What clinical syndrome is this? And trace the exact retrograde nerve route you must cover all the way to the skull base.
The clinical presentation is classic numb chin syndrome. This strongly suggests involvement of the mental nerve, which is a branch of the inferior alveolar nerve, which comes from V3, the mandibular division of the trigeminal nerve.
Okay, so trace that pathway for me. Where does your radiation field need to go?
To manage the risk of retrograde spread, we have to trace that entire V3 pathway backwards. It starts at the mental foramen, where the numbness is. Then it goes posteriorly through the mandibular canal inside the bone. It exits at the mandibular foramen on the inside of the jaw.
And then where?
From there, the main V3 trunk goes up superiorly and passes out of the skull base through the foramen ovale. Then it continues into the middle cranial fossa to the trigeminal ganglion in Meckel's cave. My radiation fields have to cover that entire pathway.
Perfect tracing. That's a critical detail. Teaching Pearl. Numb chin syndrome mandates V3 pathway planning. You must trace the PNI from the mental foramen through the mandibular canal to the foramen ovale at the skull base. Okay, let's talk treatment. An MRI shows some subtle enhancement at the foramen ovale, suggesting microscopic involvement. What dose do you prescribe to that nerve tract? And, based on the evidence, do you add chemo in this PN0 margin-negative case that's driven only by PNI?
For high-risk microscopic PNI along a named nerve, which is what this sounds like, the standard dose to the entire pathway all the way to the foramen ovale is 60 gray.
And what if the margin on the nerve itself was positive, or there was gross disease on MRI?
If there were gross disease on imaging or a positive nerve margin, then I would escalate the dose in that specific area to 66 or even 70 gray.
Okay, now the chemo question. PNI is high risk. Do you add cisplatin?
I would generally treat this patient with radiation therapy alone.
Why?
Because the level 1 evidence from RTOG 9501 and EORTC doesn't support it. While PNI is a powerful predictor of failure, PNI by itself, in a node-negative, margin-negative patient, wasn't one of the factors that showed an overall survival benefit from adding chemo. The benefit was really driven by positive margins in E&E. So the board-safe standard approach is high-dose radiation alone to control that spread along the nerve.
That is the critical distinction. PNI is a radiation target, not necessarily a chemo trigger. Teaching Pearl. Chemotherapy is not automatic for PNI alone in the absence of E&E or a positive margin reserve chemo for the highest risk evidence triggers.
Okay, a field design twist for block 3. A different patient. A 2-centimeter well-lateralized buccal lesion, margins negative, no PNI, clinically N0. Do you treat the contralateral neck?
No, I would not. For a truly well-lateralized, early-stage buccal mucosa cancer with no other high-risk features, the risk of occult contralateral disease is exceedingly low, often less than 5%.
So what's the advantage of staying ipsilateral?
By limiting treatment to the ipsilateral neck, we can completely spare the contralateral parotid and submandibular glands. This dramatically reduces the long-term toxicity of xerostomia and dysphagia, and we can do it without compromising oncologic safety in this very select group. Exactly. Selection is everything. Teaching Pearl. Buccal mucosa provides one of the cleanest scenarios for strict ipsilateral-only neck coverage when the primary is truly lateralized and lacks high-risk features. Block 4. Retromolar trigone, the gateway case. A patient has a left retromolar trigone SCC. It's about 3 centimeters, and he has new trismus difficulty opening his mouth. Imaging shows deep extension with involvement of the masticator space. Why do we call the RMT a gateway subsite? And what T category does masticator space involvement imply?
The retromolar trigone, or RMT, is called the gateway because of its dangerous location. It sits right at the junction of the oral cavity and oropharynx, with direct access to multiple deep corridors, the pterygoid muscles, the masticator space, the parapharyngeal space, all leading right up toward the skull base.
And how does that relate to his trismus?
The trismus is a huge clinical red flag. It almost always means deep invasion into the pterygoid muscles, which control the jaw. According to AJCC 8th edition, invasion into the masticator space automatically makes this a T4B tumor.
The critical staging pivot, T4B, teaching pearl. Trismus in an oral cavity primary should make you immediately fear deep space invasion, and confirmed involvement of the masticator space is the definition of P4B. So this patient is T4B and 0. The surgeon is asking for your input on modality. Is this a surgery first case, or are you leaning toward definitive chemoradiation?
This is where the T4B designation really changes the paradigm. While surgery is the default for most oral cavity cancer for T4BRMT, it's often not the best choice. The decision really pivots on resectability and the expected functional morbidity.
What makes it so hard to resect?
Well, because it's so close to the pterygoid plates and the skull base, getting negative margins on a T4B tumor there is exceptionally difficult. Even if it's technically possible, the functional cost is often devastating.
What kind of functional cost?
You're talking about a massive surgery that would guarantee profound, permanent trismus, severe dysphagia, and major cosmetic changes. So if achieving negative margins is unlikely, or if the functional deficit would be that catastrophic, then definitive concurrent chemoradiation becomes the preferred option. We aim to preserve function while still giving the best chance for cure.
That's the key. Function and resectability have to override the surgery-first reflex here. Teaching pearl. For T4B biology in the oral cavity, the surgery-first reflex often breaks down. Resectability and expected long-term function must drive the modality selection. Twist for block 4. Alternate scenario, a resectable T3 and 0 RMT, surgery is done. Post-op path shows the deepest margin is close less than 1 millimeter, but not positive, no ENE. Do you add chemo? And what's your dose strategy for that close margin?
I would treat this patient with post-operative radiation therapy alone. A close margin is not a positive margin, so it doesn't trigger the need for chemo based on the landmark trials. The risk from a close margin is increased local failure, and we address that with radiation dose.
How so? How do you adjust the dose?
The standard 60 gray to the high-risk bed might not be enough, so I would use an SIB approach to dose escalate the specific area of the close margin. While the rest of the high-risk bed gets 60 gray, that CTV covering the close margin interface would be boosted to 63 or maybe even 66 gray, as long as we respect our organ at-risk constraints. We address the risk by boosting the radiation, not by adding cisplatin.
A critical distinction for both boards and clinic. Teaching pearl. Close margin is not positive margin. The solution is to boost the radiation dose to the high-risk interface, not to automatically add concurrent cisplatin. All right, our final case. Block 5. Lip. A 75-year-old farmer with a 1.5 centimeter squamous cell carcinoma of the lower lip. Clinically N0. Definitive radiation is planned. Describe your technique, focusing on how you protect the underlying structures.
Treating the lip with definitive radiation is really a geometry and shielding problem. For a small superficial lesion like this, I'd use electrons or maybe orthovoltage, depending on the depth. The goal is to use a beam that doesn't penetrate too deeply.
And how do you protect the teeth and mandible?
The absolutely critical piece of equipment is a custom-made internal shield. It's usually made of lead, coated in wax or plastic, and we insert it into the mouth right behind the lip.
And what does that shield do?
It does two things. First, it blocks the dose to the teeth roots and the gingiva, and more importantly, it shields the underlying mandible from getting a high dose, which dramatically reduces the risk of osteoradionecrosis later on. We also have to use bolus on the outside of the lip to make sure the skin surface gets the full dose.
Perfect. It's all about the setup. Teaching pearl. Lip SCC is a geometry problem. Always choose a beam that fits the shallow depth and protect the mandible and teeth with a customized internal shield. This patient is older, he lives far away, and he'd like a shorter course of treatment. Is hypofractionation appropriate for an early-stage lip cancer?
Yes, absolutely. Hypofractionated or shortened regimens are very common and appropriate for early-stage lip cancer. We can use slightly higher daily doses over, say, 4 to 5 weeks instead of the traditional 6 or 7. The historical data shows excellent local control rates with these schedules.
And what do you counsel him about control and cosmesis?
I'd tell him that local control is exceptionally high, 90 to 95%, which is just as good as surgery. And cosmetically, radiation often gives a better long-term result than a big surgical excision. I would warn him, though, that the acute side effects, the pain, swelling, the skin reaction on his lip, will still happen, and might even be a bit more intense with the higher daily dose. Convenience can't compromise quality.
Agreed. Quality of delivery is always number one. Teaching Pearl. For early lip SCC, shortened courses using hypofractionation can be reasonable and safe. Just ensure that convenience doesn't lead to any compromise in setup, immobilization, or dose coverage. Excellent work. We've navigated 5 very complex oral cavity cases. Let's do a quick final recap of the highest yield points.
I think it starts with staging, the absolute necessity of using AJCC 8th edition, and especially the role of depth of invasion, remembering 5 millimeters and 10 millimeters as the key DOI thresholds that really drive the T stage.
Absolutely. And building on that, we anchored all our adjuvant decisions to the landmark trials, RTOG 9501 and EORTC 22931. And you correctly identified the 2 non-negotiable triggers for adding concurrent chemotherapy.
Right, a positive surgical margin and the presence of extranodal extension, ENE. And we made it clear that intermediate risk features, like multiple positive nodes without ENE, get dose-escalated radiation alone.
We also covered the detailed anatomy of PNI, tracing the V3 pathway all the way to the foramen oval at the skull base.
And finally, we hit those key T4 distinctions, T4A being bone invasion into the marrow versus T4B involving the masticator space, and understanding how a T4B diagnosis can completely shift the treatment paradigm toward definitive chemoradiation to preserve function.
That is exactly how you master this section. By navigating the toughest staging and adjuvant decision points with evidence and detailed anatomical knowledge. Well done.
Thank you. Those were challenging cases.
To complete practice oral boards and access comprehensive deep dives into all head and neck subsite management, visit radongsmartlearn.com. And please subscribe to Radon Smart Review for our next episode. Thanks for tuning in.